to the renal cortex. When you compare, that's why we said the comparison that you'll be comparing is to the adjacent tissues. And as you can see here, we also have the blood vessels. Most likely these are the hepatic vessels, and the one with the bright edges, this is the portal vein. And as you can see, inside it has no internal echoes, and that is what is known as anechoic. So in just to recap, is that in abdominal POCUS, we will actually be focusing on some of the things. Like in trauma, you want to check if there's any pneumothorax. In the liver, we said actually the liver is the largest solid organ, and it is found in the right upper quadrant, so that you're able to identify where those areas, what would be on the right upper quadrant and what would be on the left. So usually the lungs, of course, is in the thoracic cavity, both right and the left. And what would we be checking is for pneumothorax, especially in trauma. Then we have liver, which is the largest solid organ and is found in the right upper quadrant. We also have the gallbladder, which is the gallbladder fossa is found under the liver. You'll actually see it on an image. Then we have the kidneys, which are usually retroperitoneal, and they are found on the right and the left, just below the liver and the spleen. And usually the right kidney appears lower than the left because it is displaced by the liver. The liver is usually much bigger than the spleen. So the spleen is found in the left upper quadrant, adjacent to the left kidney. And then we have the pelvic structures, which is the bladder, the pouch of Douglas in females, and in males, we have the retrovesical pouch. Then we have the aorta, which is also a retroperitoneal organ, and it is a midline vessel. When you put your probe in the midline on the linea alba, the dark line in between on the abdomen, that is where you will find the aorta. It is a midline structure. So then we have some of the other things. We start with the lungs, and in the lungs, what we usually want to check is what is known as the A lines, and we also have what is known as B lines. So the A lines in this case, you can see this is the pleura of the lung. Then it has this replicating thing, which is known as reverberation. Remember, that's why I talked about the artifact. And one of the artifacts in this case here, what we are seeing is what is known as reverberation artifact. But it is actually a good artifact. When we are able to see the pleural line there, and then we have the reverberation artifact, and which is known as the A lines, then it means that is a normal lung. And we can also, there is also the sliding sign. When the patient breathes in and out, you'll be able to see the pleura being able to slide over. You actually see it as if it is sliding as the patient breathes in. So if there's that sliding sign, then that is a normal lung. It has no injury. Then we have what is known as the B lines. You can see there we have these artifacts that also goes down like that. That is what is known as the B lines as well. So the pleura sliding sign and the presence of A and B lines suggests that there is no pneumothorax. That is why it is important for you to actually understand what the A line and the B line would look like. So both of those, if you're able to see that kind of artifact, the reverberation artifact, and we also have this artifact, you see these B lines here is what is known as ring down artifacts. You can see that ring down artifact. It's like, it's a ring down, it's going down. That is a normal lung. If you see the A lines, it is still a normal lung. So if you don't see these two, then it means that lung could actually have an issue. So then we want to see the liver in comparison to the right kidney there, and we see the spleen and the left kidney. You can see the way they are adjacent to each other. And in each of them, there is that potential space, which you see that interface that is in between, that is a potential space. On the right side, it is known as the Morrison's pouch. And usually when there is injury during trauma and there is internal bleeding, because these are potential spaces, then fluid would collect in that area. Same as the spleen and the left kidney. As you can see there, there is also another interface, and that could be suggestive of, internal bleeding if you find fluid that is anechoic in between there, or even just any fluid that is separating the two interfaces, because they should be same interfaces. Then as you can see here, we also have the gallbladder. It is important to understand how it looks like. And as you can see, it is actually found just, the gallbladder fossa is adjacent to the left lobe of the liver. So just adjacent to that sharp edge of the left lobe of the liver, then we have the gallbladder here. And the gallbladder, we have what is the parts of the gallbladder. We have the fundus here. We have the body, which is the midsection. Then we have the neck. And you can sometimes have pathologies like pericholecystitis. And you'll actually see this thin, you can see the thin, you can see the thin line there that goes all the way around like that. Yeah, that would be actually compromised. So you'll not be able to see it as a thin line, but then it will appear like a double line and there is fluid in between. And that would be suggestive of cholecystitis. So some of the patients will actually present in our department with acute upper quadrant pain. And one of the things that you should be thinking about is actually acute cholecystitis. And how do you differentiate? It is by knowing how the normal gallbladder looks like. And the wall thickness in most cases for the gallbladder, a normal wall thickness should be between 1 to 3 millimeters. After 3 millimeters, then it becomes a thickened gallbladder wall, and that would be suggestive of cholecystitis. So then what else do we see on that same plane? We are also able to see the portal triad, and the portal triad is actually the Mickey Mouse. You can see this is like the face of the Mickey Mouse, and we have two vessels there. And these two vessels, in most cases, this would be the hepatic artery proper. And then we have the CBD, which is the common bile duct, and we will also have the main portal vein. That is when you just want to assess and see, is the CBD dilated or not, especially when there are stones. And they could be stones that are distal, like it could be extrahepatic, which is known as choledocholithiasis. That means the stone is not actually in the gallbladder, but has already passed through the neck and gone into the CBD, and probably even extrahepatic. It is probably in the maybe ampulla ovata where it meets with the pancreas. And in that case, this CBD would be dilated. It would actually not appear this small. You'd see something that is so huge that is dilated because there is obstruction. Yeah, and that could be distal obstruction because the stone has already passed down. And of course, being that there is no bile, there is obstruction, that is, there is no bile that is being, secreted out, then it means it could cause inflammation, which in this case would be cholecystitis. So then moving forward, we want to check and see how the aorta looks like. Remember, we said the aorta is a midline structure. So you place your probe sagittally. I remember we talked about the planes. We have the sagittal plane, which the probe marker would be facing caudal, that is towards cephalad towards the patient's head, and the tail would be caudal. So when you put your probe and the pointer of that probe is facing the patient's head, that would be longitudinal plane. So that longitudinal plane, this is what we will be able to see, because when we do a transverse, then you only see a cross section of it. You see something like a cyst which is round, and that would be the transverse axis. So for the aorta, what usually happens is that from our anatomy, we know that the aorta tapers. It reduces in size as it continues down distally. So we usually just want to identify this image here. Then you measure just before the celiac trunk, and then you measure immediately after the celiac trunk, and you continue scanning all the way down until you get where it bifurcates into the right into the right common iliac and artery, and we have the left common iliac artery. So before it bifurcates, we also take a measurement around this area. This measurement should be lower than what we found in the first measurement here. In case at any course of this aorta, you measure the proximal, you measure the mid section, and you come and measure the distal section, at any time, if you find that measurement after this measurement is larger than this, then that could be an aneurysm. Because we know the characteristics of the aorta is that it should actually be tapering in a healthy patient. So that is why it is important for us to be able to identify the aorta and know what to measure and even remember its characteristic, how the aorta is. Then we have the aorta there in transverse, as you can see. You see, this is a cross-sectional view. This is a vertebral body, and that is one of the vertebral bones. And as we said, it casts what? A shadow. You can see there is shadowing behind it because it is a very high reflective interface. So we have the aorta here, as you can see. This is in transverse view. We also have the inferior vena cava here, and that is also on a transverse view. And how you're able to distinguish the two is that the aorta would be more medial, and when you compress, when you put some probe pressure, this one will actually collapse and close completely, which is the vein. And then whatever remains as a pulsatile, because it has rigid walls, that is what is the aorta. Because sometimes you can find aneurysms that look so huge and you think this could be the IVC, because the IVC usually, it is hammock shaped at the entryway, it gets into the liver. Sometimes it appears very big, more than the aorta. So when you're not very sure, is this the vena cava, inferior vena cava, or is it the aorta, what you do is you just compress the probe. And you can do that. You actually compress the probe when you're on a transverse view so that you see it as it closes. And if it doesn't close, then that is the aorta. If by any chance the inferior vena cava also doesn't close, it means there could be a thrombus. So it is still something that you need to do while you're scanning. So then moving forward, we have the female pelvic region. And some of the things that we want to identify here is the normal anatomy of that pelvic region. So in the female pelvic region, we usually have the bladder, and you can see here the bladder, it is anechoic. The content inside, which is urine, is actually anechoic. The white area you're seeing here is just an artifact. But in essence, if you were to change the angulation of the probe where this image was acquired from, you would actually lose this, and that would tell you that was an artifact. And then, so just anterior to the uterus, you can see the uterus is this. You see this structure here. This is the vaginal canal, the one that starts going up, it narrows. That is the vaginal canal. But between here, somewhere here and here, that is the cervix. And then we have the body of the uterus would be the midsection. Then, of course, we have the fundus. And you can see this dark structure here is actually edge shadowing. And because the bladder is actually a cystic structure. So there would be edge shadowing there. So then the other thing that we have is you'll see the uterus here on a different view, but this was a transvaginal. But I just wanted to show you the body of the uterus there, and even how you see the cervix here is actually moving upwards because of the acquisition. This one was a transverse. This was a transvaginal image. You can see the footprint of the probe there is different from this, which is transabdominal. But in most cases, when we are doing POCUS, we would actually be using a transabdominal probe, which is the curvilinear probe, and it is the low frequency probe that is between 2 to 5 megahertz. So in the one of the other things that you need to know is the pouch of Douglas, and we said there is also a potential space behind every visceral organ. And in this case, this space that is behind here, behind in the uterus, is actually the pouch of Douglas, and it is a potential space as well. When there is injury in the pelvic area, or when you have inflammation, because some of these patients will come with acute pain and they are telling you all the pain that they feel is around the pelvic region. Sometimes they could be having a pelvic inflammatory disease, and fluid would actually collect behind the pouch of Douglas there. Then we have in the males, we will have the bladder. You can still see that the bladder is actually anterior, and then we have the prostate here, and we have the rectum here. So we have the retrovesical pouch, which is in between the bladder and the prostate there. It could still be a potential space. There's also potential space between the prostate and the rectum. Anytime you find that there is any interface between two organs or two visceral organs, there is always a potential space. And that potential space could collect fluid when there is inflammation or when there is trauma and they are having internal bleeding, or even a ruptured ectopic. When there is a ruptured ectopic, you will also see fluid collection around the pelvic region and even the Morrison's pouch. So then, what are the abdominal standard scanning windows? We have what is known as a subxiphoid window, and I'll be able to show you that in an image. And in most cases, in this subxiphoid window, we actually want to check pericardial free fluid because it is the easiest access to the heart. Then we also have what is known as a mid-clavicular intercostal window. Sorry for that. We have what is known as a mid-clavicular intercostal window, and we'll be checking the gallbladder in that window. Then we have the subcostal window, which we use to measure actually the length of the liver. We don't just measure it from any other window. Then we have the mid-axillary line window, where we will be checking the Morrison's pouch or even the splenorenal recess. And we also want to compare the echogenicity of the kidney and the liver, because in most cases, the kidney and the liver should be either isoechoic, which we said, or the kidneys usually appear slightly darker than the liver. If you find a phenomenon whereby you see the kidneys is brighter than the liver, then that would also suggest that there's pathology like pyelonephritis. Yeah, because that is inflammation of the cortex of the kidney. So you will be able to see that from the mid-axillary window to be able to compare both the liver and the right kidney, or the spleen and the left kidney. So as you can see here, this is when we want to check the cardiac assessment. When you want to do that quick assessment, you'll actually place your probe here, which is the subxiphoid window, and you angulate it north. Yeah, when you're doing the maneuvers, the probe maneuvers, we have those rocking, sliding, and all that. So in this case, you will actually angulate your probe like you're touching it to face up into the chest there, because you can see this is the thoracic cavity. So you place your probe there on transverse and actually angulate it like you're trying to torch. It's like you're putting a torch and trying to see from below what is up there. That is how you're able to see the pericardial effusion. Then we have in abdominal, which we've been talking about when we're assessing free fluid. We will check it from the different windows. We have the subxiphoid window there. We have the mid-axillary here, where we will be comparing the liver and the right kidney. Here, the same view, we will be assessing the spleen and the left kidney, even for the potential spaces like the splenorenal recess and the Morrison's pouch in this angle. Here we'll be checking in the subxiphoid window, of course, we will also be assessing the heart and even just the bowels that are up high here, which are the small bowels. And then we have the pelvic region, where you'll be assessing either the Morrison's, the pouch of Douglas, or you're actually checking the retrovascular space. Then we have lung, which this one we will discuss at a different forum. But in this image, I was trying to just highlight and show you that this is all point of care. Like, for example, the lung, you have to place it in the different levels. Like here, you'll be checking the epices. Here, you want to check the subcostal spaces and all that. So you'll be able to assess that. And we said you'll be checking whether there is the A lines and the B lines and all that. Yeah. So then we have the probe. Which probe are we using? We said that we are using a low frequency probe because the lower the frequency, the deeper the penetration. And in this case, of course, the patient would be lying supine so that you're able to assess. Then we have sometimes when you've really done well with your POCUS, like abdominal, you can also use the linear probe to be able to check if there are any rib fractures. And what would we be looking at? We're just checking for discontinuation if the bone is straight, you just see it as straight as it is supposed to be. But if there is a fracture, then you see the discontinuation of that bone. But then that would be a chest X-ray, of course, would be better to be able to do that. But in small kids, you can actually utilize the linear probe, and it will also show you rib fractures. Then, so what would be the indications for liver POCUS? We would have trauma. Sometimes there is hepatomegaly. When you do your physical examination as a physician, you can feel that this organ actually feels like it is large, it is bigger than what I would expect. So you could put your probe there. And of course, we said that we measure the liver from the subcostal window. You don't measure it from any other window. The window for measurement, and it is the only reason why we use the subcostal window, is just for measurement. We don't check any other thing. Then you also want to see if they could be masses or they could be abscesses, and masses could range from hemangiomas to metastases, and of course they usually have different characteristics on ultrasound. Like hemangiomas would appear very bright. You remember that image that looked like the one we were saying it is echogenic and all that? That is how hemangiomas look like in the liver. And if it is metastasis, we have things like the target sign. And sometimes they could also be tumors of the liver, which is primary to the liver, like the HCC. In those cases, you'd actually see masses that are either heterogeneous or they appear homogeneous to the liver. So those are some of the things you'll be checking. Even liver abscesses. Why would you actually want to say you want to do that liver POCUS? Because if this patient has very high fever and you're wondering what could be the problem, and you put your probe there, and abscesses actually usually have that, heterogeneous characteristics. It looks like it's casting shadows. Sometimes those abscesses have double walls and all that. Then, of course, what would you be scanning? We said we will use the subcostal windows, intercostal window, especially to check the gallbladder. Then we also have the mid-axillary, which we are comparing the liver or the spleen to the kidneys. Then, of course, what is our aim? We want to see if there is any free fluid in the Morrison's pouch, and if there are any lesions, and if there is any echotexture change. And echotexture change could mean, remember we said the liver usually looks homogeneous, and it looks hypoechoic usually. But sometimes, for example, when somebody has, let's say, liver cirrhosis, sometimes that liver actually looks smaller, and when you measure it, it would be less than 15 centimeters. And it would also appear too dark. It would be darker than the normal, what you're used to. And that's why, of course, I always emphasize that during your hands-on, you make sure that you get the normals as many as possible, so that when you see an abnormal one, it will be actually very certain that this is not normal, because you're used to what is normal. Then we have, why would we be doing POCUS of the gallbladder? Sometimes we want to, patients just come in with right upper quadrant pain. They could be having gallstones. They could be having cholecystitis. And that acute pain is actually, could be cholecystitis, as opposed to chronic cholecystitis. Sometimes there is no pain, but the gallbladder wall would be thickened, too thickened, and it could be brighter than even the gallbladder itself, and doesn't have that pericholecystic fluid that is around it. You'll be able to see. So some of the findings that we find, of course, we said they could be gallstones, which could be either mobile or they could even be static. And how do you tell they're mobile? Is you rotate, you turn, you ask the patient to turn as you keep your probe steady, so that you see if the stones are actually being displaced or not. And then, of course, most of the gallstones would be casting shadows, because it has a lot of calcium in it, and therefore it would cast a shadow. Then there is always wall thickening, in case there is anything that is above 3 millimeters, could either be acute cholecystitis or chronic cholecystitis, depending on the appearance of that wall. Then we have that pericholecystic fluid. Pericholecystic fluid is actually characteristic of cholecystitis, acute cholecystitis. Then we have sonographic Murphy sign, and the sonographic Murphy sign is there's a xiphoid window there where you place your probe. You actually apply some pressure. Like in ultrasound, that would be a maneuver known as compression, using the probe. And you will actually see the patient, jumping up with a lot of pain. And there we would say the patient has a positive Murphy sign and could be suggestive of cholecystitis. Yeah. Then we have the kidney POCUS, where would be checking that a patient could come with just unexplained flank pain. They tell you they have some dull pain, and that could range from either appendicitis to kidney stones to pyelonephritis, to even acute kidney injury. So you need to, those are some of the indications that you would actually warrant you to do a kidney POCUS. Then, of course, the technique, we said that all the time while you're doing any form of POCUS, any kind of ultrasound scan, you have to check in both planes, which is the longitudinal and the transverse sweeps. Then sometimes you also find hydronephrosis. And of course, for us sonographers, you'd be able to grade it and say this is grade 1, grade 2, grade 3. But in your practice, I just want you to know how a normal kidney would appear and when it has hydronephrosis. The stones, they would also appear the same. They could be masses, which, for example, like the renal cell carcinomas, you'll be able to see most of the time they affect the serosal part of the kidney. But then it not necessarily means that it is RCC. You can just confirm, of course, any type of cancer with biopsy. But sometimes they could just be pointers. And in most cases, what I have seen about RCC is that most of those masses are actually isoechoic to the kidney. It takes a very keen eye to be able to see that, no, there's a lesion there that I can be able to see. Then, of course, the spleen, we said its location is in the left upper quadrant, and it is tucked under the left hemidiaphragm. Then we also have the indications, trauma, where they could be splenic rupture, especially during trauma. They could also be splenomegaly when you're doing your physical exam and you're able to see that the organ actually feels like it's big, more than normal. And then you'd be able to ask what is the normal size. The normal size of the spleen is usually 11 to 13 centimeters. Anything that is above 13 centimeters for the spleen is actually splenomegaly. And why we say 11 to 13 is there are patients who are very tall and their body habitus, of course, dictates that they also have bigger organs. But then 13 centimeters is usually the cutoff, especially for our population around this area. Maybe when you go to different other countries where people are way taller, maybe they have different cutoffs. So then we have the liver, we said its cutoff points is 15 to 17 centimeters. Anything that is clearly above, like myself, I'm a 5'2". So being a 5'2", if I have a 17 centimeter liver, that would be hepatomegaly. Because using my body habitus, I would estimate that mine should not be more than 15 centimeters. For my spleen, probably it shouldn't be more than 11, as opposed to someone else who is much taller than me, probably 6'2", 6. Those ones would probably now have the higher cutoff. And of course, the technique is that we said you use the low frequency probe, which in this case is the Cavillina probe. And you use the left upper quadrant intercostal and subcostal windows, just like when you're assessing the liver. And you check the splenorenal recess, and that is the space between the spleen and the left kidney. So moving forward, we have how would the spleen appear? A normal spleen, just like the liver, it would appear homogeneous. It has that homogeneous uniform ecotexture, and it has smooth contours. For the splenomegaly, you'll be able to see an enlarged spleen, and it is clinically important to note because, of course, as doctors, when you're doing your physical examination, you can actually be able to tell. Then we will also, there is also splenic injury, and in this case, we'll be able to see subcapsular hematoma. And in most cases, they actually appear crescentic. They appear like a crescent adjacent to the spleen. And there you could actually know that that is a subcapsular hematoma. Then we have associated free fluid when there is splenic injury. And some of the pitfalls that we find when we are assessing the spleen and the liver is that they could be ribs and lung shadowing, and also bowel gas. And posterior location may also hide some small collections. Then we have in trauma, always scan the left upper quadrant carefully, because small amount of fluid could actually collect in the splenorenal recess before anywhere else. So sometimes we are very quick to check like the obvious one, which is the Morrison's pouch, but then the splenorenal, you have to make sure that you actually scan it more carefully, because it is more posteriorly, and therefore you may not have a very good window like when you have the liver window, because the liver appears very big, and the liver would actually act as an acoustic window for you to be able to see that space. And same as the spleen, but remember the spleen is much smaller. And then of course in females, in would be checking, why do we also do the bladder POCUS? And some of the things, the indication is urinary retention. Somebody presents to the department in your casualty and they are not able to pass urine maybe for the last 1 day or 2 days, and their bladder is completely over distended. Some of the things that you could just put your probe there is to check, like, is it really the bladder? And in most cases, when the bladder is over distended, it would appear globular. It looks like a round structure as opposed to the normal appearance of the structure, that bladder that we are used to. And then, of course, most of these patients will present with just generalized pelvic pain, and it could actually be the bladder. Maybe they have cystitis, and clinically, cystitis would be a thickened urinary bladder wall, and the cutoffs for the urinary bladder, usually when it is full, it is 3 millimeters. That is the wall, and we measure the anterior wall. When it is empty, it should not be more than, or maybe let's say suboptimally distended, it should not be more than 6 millimeters. So those are the cutoffs. If there is anything that is thicker than that, then start thinking about cystitis. And then we have, of course, in women, we have retention in pelvic pathologies, and also we could have ectopic pregnancy, which is, which is not ruptured yet, and we could also have an ectopic pregnancy that has already ruptured, because that is how they end up as emergency, and they need like a POCUS. So when we are doing E-FAST exam, the indications, of course, is usually trauma, when somebody presents with hypotension and the patient is unstable. Some of the things that we do is, one, we have the first view that we check is the right upper quadrant, which we are assessing the Morrison's pouch to check if there is any fluid collection between that interface. Then we have the left upper quadrant, which is the splenorenal recess. And in that case, we have fluid collecting between the spleen and the left kidney. Then we have the pelvic region, which could be the pouch of Douglas or the retrovesical pouch for males. We could also have pericardial collection, which is an effusion, and we could have subxiphoid window, and that is where you place your probe at the xiphisternum, and you're able to actually angulate your probe, and you angulate it north. That is where you will find the heart. So what is the gold standard? Why do we want to do actually an E-FAST examination? We just want to check if there is any free fluid. And if there is any free fluid, it doesn't matter where, it doesn't matter the amount. The fact is, if there is any free fluid, then there must be internal bleeding. It helps you to just make a quick decision, and you're able to save the patient's life. Then the free fluid detection sites is usually, we've said, the Morrison's pouch, we have the splenorenal recess, we have the pelvis, we have the paracolic gutters, and even adjacent to the pancreas, though I didn't want us to go to the pancreas as much because it's a bit complicated. Then we would have a potential space just behind the pancreas, which is known as the lesser sac. That is also another potential space. And of course, if the pancreas also, it usually appears as homogeneous, and it has diverse appearance with different age groups. In more older people, the pancreas would appear hyper-echoic. In younger individuals, maybe middle-aged, it would appear darker, which would be hypoechoic. But the most important thing is, when you're checking the spleen, for example, the pancreas, you're not supposed to see the pancreatic duct at any point. If you're seeing a pancreatic duct, then it means there is pancreatitis. And it could be alcoholic pancreatitis, it could be any form of pancreatitis, but the fact that you can see the pancreatic duct, which is a midline structure in the pancreas itself. You will see it running in the middle of the pancreas. That one, it would appear like a tubular structure, and that would be the splenic duct. The splenic duct should never be more than 1 millimeter. If it is more than 1 millimeter, then there could be pancreatitis. So these fluid detection sites that we said are potential spaces, which we've said is the Morrison's pouch, the splenorenal, the pelvis, the paracolic gutters, the lesser sac, and all that. What would be the appearance? You would see black anechoic fluid pockets, which are not supposed to be there. And of course, we use it in trauma. Sometimes there is a ruptured ectopic, as I said. In ruptured ectopic, in most cases, you will find free fluid in the Morrison's pouch. And then they could also be post-operative bleed, maybe post-surgery. Somebody is bleeding, and you could actually see free fluid. And it could mean that maybe there was no, maybe the closure was not adequate, or that patient is bleeding from the vessels and all that. And therefore, that focus becomes very important, because you need to put your probe there. If you see anything that appears like fluid collection, which is anechoic or hypoechoic, yeah, and you can actually, when you apply some probe pressure, you can see it moving, yeah, then that would mean there is free fluid. And it is very important that in women, we have to note that with our different menstrual cycle, sometimes we tend to have physiological free fluid in the Morrison's pouch, and it could also be pathological. So when it is physiological, if you were to do a volume, and a volume, of course, we always get it on both planes. You get one measurement, which is, let's say, the length on the longitudinal. The other one, which is the transverse, you get the width and the depth. Then you are able to get a volume. Any volume that is more than 1 centimeter cubic would mean that that is pathological. But when it is less, then it is physiological. It is just supposed to be there. So I wanted to show you a small video here. Oops. So I don't know if you're able to see the video. Anyone? Are you able to see the video?
Yes, we can.
Okay. And is there sound? Is there sound?
No sound.
Okay, now?
Or in trauma.
Is sound?
You're basically looking.
You
Yes,
can be
it's
able to
sound
hear
now.
sound now? Okay, thank you. So let's start from here.
So now we're going to go over how to perform the FAST scan. And this is a scan that's used in trauma. It's called a focus assessment using sonography for trauma or in trauma. You're basically looking for free fluid in the abdomen, around the heart, in the chest, as well as looking for pneumothorax of the chest. So we're just going to go over the protocol that I use. So here we're going to use the phased array probe. The patient is going to be in a supine position because it's in a trauma setting, so they're usually lying flat. You're going to put the probe, you're going to assess the right upper quadrant, the left upper quadrant, the pelvis, and then you're going to assess the heart, and then the lungs. And we'll go over through it in that order. So the first scan is a right upper quadrant scan. So here is a right upper quadrant scan. Indicators up towards the head. It's around the 8th to 10th intercostal space in the mid-axillary line. And you're looking for Morrison's pouch, the space between the liver and the kidney, for free fluid. Make sure, in addition, you look towards the edge of the liver, because sometimes fluid can track there also. The next scan you're going to do is the left upper quadrant scan. So this is knuckles to the bed, looking for fluid around the spleen. And here we see the spleen. And the fluid doesn't track between the spleen and the kidney usually unless there's rupture of the splenorenal ligament. In addition to looking at fluid around the spleen, you want to look above the diaphragm, looking for any fluid in the chest. And here you see a good mirror artifact sign. There's no fluid there. That's completely normal. And remember to also do this on the right upper quadrant, looking for fluid in the right chest. The next portion is going to be the pelvic scan. Here, you're looking for free fluid above the bladder. So indicator is up towards the head. And you see the bladder here. There's no free fluid above the bladder. Another organ to identify is the prostate in this view. And free fluid, once again, is above the prostate and above the bladder. The next view is going to be the cardiac view, looking for pericardial effusion. And there's two views you can use. You can use either the subxiphoid view. And since this is on the standard mode, the indicator is going to be towards the patient's right side. And you're going to identify the liver and sweep in and look for that heart. And here we see the heart, the four chambers of the heart. And when the patient takes a big breath in, brings it closer, you get a better view, that subxiphoid view, looking for pericardial effusion around the right ventricle or left ventricle, and looking for any collapse of these ventricles, signifying tamponade, specifically right ventricular diastolic collapse or right atrial systolic collapse. Another view you can use, if you can't get a good subxiphoid view, is a peristernal long axis view. And once again, since we're in standard mode, the indicator is going to be towards the patient's left hip. So here, you're going to get peristernal long axis view. And the main thing you're looking for is pericardial effusion. You're not assessing, you don't have to necessarily assess all the heart function, but look for pericardial effusion and looking for tamponade here. And this looks normal here. You can see the pericardium both anteriorly and posteriorly in this view. And the last portion that you do is looking for pneumothorax, and that's looking for lung sliding. So once again, the indicator is going to be towards the patient's head, second intercostal space, mid-clavicular line, where you would do a needle-thoracostomy basically, and you would decrease your depth. So you see I'm decreasing my depth all the way down here. And here you're looking for lung sliding. So when the patient breathes in, so if you can take a big breath in, you see there's lung sliding on the screen there, and that indicates there's no pneumothorax. If there is no lung sliding, that is highly suggestive of pneumothorax in the setting of trauma. You want to make sure you do both the right side and the left side, looking for lung sliding. And this patient has lung sliding on both the left and right side.
Check this out. In just a sec, I'm going to speak with a different accent. And just between you and me, I don't really know.
So I don't know from this, are you able to hear to see and to hear? Maybe someone to confirm?
We can see, but I can't hear this video.
Are you able to hear or not yet?
No, I
with
can't
respect
hear.
to a female versus male patient
There?
is a female patient has a uterus.
Yes, I can hear now.
So
Thank
free
you.
fluid actually
Okay.
tracks a little bit different in
So let me start it over. Sorry. Yeah.
So when you're performing a fast scan on a female patient, the only thing that's different with respect to a female versus male patient is a female patient has a uterus. So free fluid actually tracks a little bit different in a female. So once again, you're going to have the patient supine. The legs are going to be bent, and you're going to use a phase array transducer or a curvilinear transducer. But for the most part, we're going to use a phase array transducer for trauma. The indicator is going to be up towards the patient's head, and you're going to get that pelvic view similar to the male patient. And once again, we see the bladder. But the thing that's different is here you can identify the uterus. You can see the uterus, the vaginal stripe, as well as the endometrial stripe. And where fluid would track in a female patient is the rectouterine pouch of Douglas. And it would be just posterior to that uterus, contrary to what you would see in a male, which would be above the bladder itself.
From that, I think we've been able to have an idea of how an EFAST sorry, just a minute. Yeah, so from that, I believe we've been able to have at least an idea of how we perform an EFAST scan. And of course, beyond that, you need to keep practicing as well. And once you do that, you'll be able to get used to those structures. So we move forward to the aortic aneurysm screening. And as we said, the aorta usually tapers, and anything that the normal aorta should be less than 3 centimeters. So anything that is aneurysmic would be greater than 3 millimeters. And the greatest risk is when it gets to 5.5 centimeters. And that would actually, it is at risk for rupture. And therefore, these are some of the cutoffs that you need to know. And as I said, when you measure it before the celiac trunk on that longitudinal plane, it should progressively reduce as you go distally, as you scan downwards towards the umbilicus before it bifurcates into the iliacs, the common iliac. So we said, of course, we want to check all that in a transverse or a longitudinal and a longitudinal plane. And what we measure in this case, how are we measuring this 3 centimeters? It is actually on the transverse plane, and it would be outer to outer wall. That is how you're able to get your measurement. So you need to stress urgency should you find these figures actually being more than 3 centimeters. And then, of course, some of the limitations is when we have obese patients, it's really difficult because ultrasound biggest enemy is gas and fat. And therefore you don't get very good images, and it would be important to optimize your gains, the focus. You also use the probe maneuvers whereby you can compress, like you're pressing down, so that you reduce the distance between that subcutaneous fat and the organs that are in. Though you may not get a sharp image, but at least you'll be able to see some of those structures. And as you practice, you'll be able to actually be able to get those maneuvers naturally. They come as you do different maneuvers, you're able to get better images. So the scanning protocol for an aortic aneurysm, abdominal aortic aneurysm, is that you place the curvilinear probe in the epigastrium and scan the abdominal aorta in the transverse and in the longitudinal planes from the celiac trunk down to the bifurcation. Identify and measure the outer wall to outer wall at the proximal, at the mid, and at the distal segments. Aneurysm is diagnosed if the diameter is greater than 3 centimeters. So document the largest diameter and check if there is free fluid, if rupture is actually suspected, because there'll be actually, or if it is slow leaking. When it is beginning to rupture, then they could be slow leaking as well. And when you see free fluid around it, then that should tell you that that aneurysm probably is either slow leaking or it is just about to rupture. So it becomes an emergency, and any type of aneurysm is actually an emergency, whether as long as you just find the aorta, the diameter is, the AP diameter is more than 3 centimeters at any point. And we've said that whatever measurement you get, it should also continue tapering as it goes, as you follow it distally. So what I want us to now focus on is the image pattern recognition. We've talked about a lot of theory, but it was like a baseline so that you're able to understand and have an idea. So image pattern analysis here, we have the Morrison's pouch here. You can see here well labeled clearly is the liver. This is the right kidney. Remember, this interface in the images that we've been seeing was very thin, but in this case here, you can see all this is free fluid and this is what is mapped. But let's see the next image there. You can see this is actually free fluid. We have the liver there. We have the right kidney. Remember that interface was supposed to be this clear without any free fluid in between. And as you can see here, there is free fluid, and this is fluid in the Morrison's pouch. Probably this was a trauma patient. This could be a patient with a ruptured ectopic and they have internal bleeding and all that. So this becomes an emergency, of course. Then we have the splenorenal recess. As you can see, the normal, how we expect to see. This is the left kidney. We have the spleen there. We have the diaphragm here. And one of the artifacts that is very common with the diaphragm, because when you will put your probe there, then you see something else and you think it's another kidney or another spleen. You can see here, there is something here that looks like, you know, the parenchyma is the same as here. You can see that from, let me show you, like here you can see there's something that looks like the same as the spleen here, but what is the, separating the two is actually the diaphragm, and this is what is known as mirror artifact. It is very common, especially you will see mirror artifact of the spleen and of the liver. So you need to know that this is actually an artifact and not the true representation. So in this case here, we can see there is no free fluid in that interface. But as we go along, you can see here, we have free fluid here that has formed, yeah, between the spleen here and the left kidney. And as you can see there, we have anechoic free fluid in the splenorenal recess. Then we also have, in this case here, we can appreciate the left kidney here. This image is not very clear, but as I can see here, I have the kidney here because I can see the renal cortex. And depending on, of course, where my probe was at that time, I would identify that this is actually the left kidney. And this is the renal sinus. This is the renal cortex. But then around it here, we have, you know, it looks chaotic and all that. There is free fluid. There is a hematoma. It's heterogeneous. So this could possibly be a ruptured spleen. And remember, the spleen is highly vascularized. So you would see a lot of fluid around it. You would see hematomas which appear. They range from hypoechoic to heterogeneous lesions around. Then we have the retroperitoneum. And of course, we can see here, we have the bladder here. And this fluid is just sitting around the pelvic region. Remember, this is distinctively the bladder and we can see the wall there. But then there is this fluid here which we don't expect to see. And this is retroperitoneal fluid. So there could be something that is going on. Could be inflammation, could be chronic disease, could be anything. But all these patients with even they could present with abdominal distension. And you just put your probe there, you can see there's fluid collection. Maybe there's ascites from a chronic process, or it could be in trauma, it could be in anything, but the fact is you're not supposed to be seeing free fluid around the organs. Then you can see here, we also have the bowel. Here we have bowel loops and we have the urinary bladder here. Then we have free fluid that is collecting around it. And as you can see in that, we have those free fluid collection in those areas. We are not supposed to be seeing any free fluid around the bowels and even around the bladder or anterior to the bladder. If then you put your probe and you see that fluid is there, then that should tell you that there's something wrong. So then, of course, talking about the female anatomy, this is the anatomy like in the textbook or even how you'd expect to see it on ultrasound, but this is not an ultrasound image. So what are usually the adjacent structures? you can see this is an abdominal, this is the view, a transabdominal view. There we have the bladder, and then posterior to the bladder, we have the uterus here. We can even see the endometrial stripe there. We have the rectum. Then we have the vagina just after the cervix there. Then we have the retrouterine pouch, which is also known as the pouch of Douglas, which is behind the uterus. And those are potential spaces. And this is a longitudinal view. So moving forward, you want to see, in this case, if this is a female and we have free fluid around here, remember this could be artifact, this could be, check the gains, look at these gains. There was too much, you know, the gains here were too high, and therefore that is why it is causing that artifact there. But if you were to optimize your image, you would actually get that this is clear free fluid. And this could also be as a result of the posterior acoustic enhancement from the bladder itself. So you find that that area will appear brighter because of the posterior acoustic enhancement. So here you can see we have the bladder here, we have free fluid here on top of the uterus. The uterus would be this, and it has the endometrial stripe there. And you can see there is some free fluid behind there in the pouch of Douglas. And that could be anything. It could be pelvic inflammatory disease. There is no history of trauma. But if there is history of trauma, then it means this could be fluid that is, you know, collecting because of leakages. And then this could also be, if this is an ectopic that is ruptured, you can see it will still collect free fluid. Some of these patients will come with a lot of pain. Some will come with PV bleeding and all that. So you need to just, you know, each time a patient presents in your department with acute pelvic pain, you need to have differential diagnosis in your head that could this be an ectopic? Could this be a ruptured ectopic? Could this be a pelvic inflammatory disease? Because even PID would still have fluid collecting around the pelvic area. So of course, then we have for the male, would be seeing that is the bladder. Then we have fluid that is collecting just behind the bladder, and it is on top of the prostate there. And of course, this could be also an inflammatory process, or it could be from trauma. Then you can see here for the aneurysm, this is the first image here is a transverse image. You see it's cutting along the lumen. And if you were to measure from the outer to outer, you'd probably find that this was more than 3 centimeters. And the transverse image here in A shows an enlarged aorta with a thrombus at the periphery vessels. So you can see the aorta, as we saw earlier on, should just be around nice structure, but you can see at the edges there, we have a hypoechoic rim there that doesn't go all the way, and there's even that whiteness there, and that could actually tell you that there's a thrombus. That is how they appear on ultrasound. Even this one has a thrombus. The whole of this area here is a thrombus, and the only part that is open, the lumen of the aorta, is this very small area. And that is why you see those aneurysms. What happened is because that is the weakest point. So the blood will start pooling around there, and it causes what is known as stasis, because it's just moving around and around and around, because there is more that is collecting there than is leaving. So then what it does, it actually forms a thrombus. So just to have a recap is that in POCUS, we say we use binary questions because we want to answer that, you know, POCUS is time sensitive. We have to answer questions very quickly, and you'll use it on emergencies. It's about quick decision making and whether to intervene now or not. And of course, it complements the standard ultrasound. So some of the questions that you'll be asking yourself in that binary sense is that first exam, the binary question is there free fluid in the abdomen or no? So if it is yes, then intervene. Yeah. It is not what organ is injured, how much is bleeding, and all that. You're not supposed to be measuring all those things. But then, of course, things like the aorta, if you're not sure, then you need to, it should be tapering. Those are where you have to do the measurements. Then, of course, for the aneurysm, you'd also be answering that, is the aorta aneurysmal or not? And that is where the measurement should actually come in, because each of the parameters that you're answering should have its reference point. Like the aorta, you cannot say there is an aortic aneurysm and you haven't done a measurement. Then for the gallbladder, you'll be answering things like, are there gallstones present or not? Because if there are presence of gallstones, chances are it could have, caused obstruction, or they could even be non-obstructive cholecystitis or non-obstructive cholelithiasis, which are stones. And of course, for the bladder scan, the binary question is that, is the bladder full? Is there retention or not? And how do you know there is retention? Usually we say, if the bladder was completely distended and when the patient empties and you get another volume that is more than 50 millimeters, then there is urine retention. And remember that urine retention is what will cause cystitis. Cystitis is the inflammation of the urinary bladder wall, and the measurement, as I said, when it is full, when it is well distended, it should not be more than 3 millimeters. When it is suboptimally distended, it should not be more than 6 millimeters. So of course, that is the binary questions that we are answering. It's just a repetition. Then I want us to go to the quiz. Since I know we've been talking for long, I want us to now participate, and we have a few minutes to do this. And let's try and see what we can be able to describe in this sense. So question 1, someone to try. What is it that you're seeing here? What do you think this structure is? And you can actually describe and just say, what is hyperechoic? What is hypoechoic? What structures are you seeing? Yeah? Someone to try? Is there someone who wants to try? Anyone? Tasnim?
Hi.
Johanna? Yeah?
Okay, I'd like to try.
Yeah?
So on the left, you can see the liver parenchyma,
Yeah? Yeah, that is right.
and then you also see the kidney, which
Which is
is
here.
got the same echogenicity as the liver. And between the interface, you can see a free fluid. There's
Yeah,
also
so
some.
what would you suspect? Yeah?
There's free fluid between, possibly the pouch of Morrison's.
Yeah, this is the Morrison's pouch because it is between the liver and the right kidney. And the fluid appears as?
It as anechoic.
Yeah, good. That was such a good try. That is excellent. Thank you for that. So we move on to the next question. Someone to describe and what they think about this image. This is a female. This is a patient of a female. And this is a patient of a male. Someone to try? Maybe you could try again.
Okay, good evening. For the male ultrasound, the B is anechoic. I think it's the bladder, and the P it's a prostate. I think. It's more of it's hypoechoic in comparison to the surroundings and the rectum. I think at the bottom.
Yeah, sure. So that is the bladder and the prostate there, as you can see. Then we have the rectum here. And for the female, this is actually a transverse image. We have the bladder here, same case. We have the rectum here, and we have the uterus here in transverse. So this is the uterus, and the white bright line in between there is the endometrium. So these two images, what do you think about them? What do you think about them? Are they normal or abnormal? Is this what we expect to see or not?
I could be wrong. Sorry, it's tasnemia, but I think it's normal.
Yeah, sure.
I'm
Actually,
not
that
seeing
is a
any
normal.
pathology.
Sure. That is what you expect to see. This is actually normal. Excellent. Thank you for that. Then let's move on to this next image here. And Tasmin, you could take it up. I've labeled there. We have the right kidney, not very clear, but they are labeled there. The liver, the gallbladder. What do you think is happening here?
Okay, so the resolution isn't so good, but I can see that between the liver and the gallbladder, there's some free fluid in Morrison's pouch.
But
The gallbladder is anechoic. I'm
Mhm.
assuming because of bile.
Yeah.
I won't lie, I can't really see what's going on with the right kidney, but
Yeah, the kidney is not just seen well there. But then this, you can see the fluid here is actually between the left lobe of the liver and the gallbladder.
and sorry, I just wanted to ask that other black circle that's not the free fluid and not the gallbladder. Yes, there.
That's the IVC. That would actually be
Okay.
the IVC. Yeah.
Okay, that makes sense. Thank you.
Yeah, thank you. So thanks for that try. Good trial. At least I can now see that you understood what, I was talking about. Then we have the spleen here. The image here is of the spleen, and I want to demarcate for you how the spleen looks like all round there, all round, all the way. That is the spleen, this entire thing. What do you think is happening here? And this is free fluid. What should be the normal appearance of the spleen in terms of echogenicity? What should it be?
So the normal echogenicity, it should be homogeneous, but this is looking more heterogeneous.
Good.
There's areas of hypoechogenicity compared to the rest of the spleen. I can also see there's a little arrow with the free fluid.
Yeah.
So there's probably some type of pathology within the spleen.
Yeah, and this could be hematomas. Yeah.
Would an
this is-
abscess, sorry, would an abscess also show up as hypoechoic?
Yeah, an abscess would show as an hypoechoic, but it would depend on the history.
Okay.
Because if this is a trauma patient, this could be hematoma because of acute splenal injury.
Okay.
But then also for abscesses, they have diverse appearance, but also the patient would be presenting with fever. If a patient doesn't present with fever, if you see this on the spleen, it wouldn't point to an abscess.
Okay, that obviously makes sense. Thank you.
Yeah, sure. So then we have that image here, someone to try, and this is the bladder. I've labeled there, this is the urinary bladder. What do you think this could be? And the urinary bladder is the entire thing, including the red part that I have circled there. So this entire thing here is the urinary bladder. What do you think about this bladder? In relation to what we've learned today, what could you think about? If it was trauma, what could that be? Someone to try? Okay, maybe this is a difficult one, but then this is a bladder, and this would most likely be a hematoma from trauma, because if the entire thing here is the bladder, then we don't expect to see this area of heterogeneity if this is trauma. If it is not trauma, then this could also be, urinary bladder filling defects, which could point even to some of carcinomas of the bladder, because they usually would appear like solid structures. It can be anything. Yeah. that is why the patient's history would be important. This patient would most likely also present with hematuria and all that. So even the ones with the acute pain from trauma, and you see such a thing, then it means there is injury to the urinary bladder or even the kidney, and therefore that blood is coming down through the ureters and it is collecting in the bladder. Yeah, those are some of the things that you would think about just having the system in your mind. So then I think we have our last question here, and this image doesn't really look very clear, but here we have a full bladder and we have another full bladder here. We have the vaginal stripe there, we have the uterus, and therefore this also is the seminal vesicles, and this is male, of course. So what could be the diagnosis here is that this is just normal findings for both the male and the female. So what is our take home today? Most of the time when we are thinking about trauma, you need to check the liver, the spleen, the gallbladder, the potential spaces, both in the abdomen and in the pelvis. And then, of course, in EFAST, what you want to check is mostly free fluid. In aortic aneurysm, they are life-threatening, of course, if they are missed. And therefore, it is important for you when you're checking any other organ, don't forget to check the aorta. Then, of course, that marks the end of our lecture today. Unless there is anybody with a question, then you're welcome to ask or any additionals.
Thank you so much. I think that was a really good lecture.
You're welcome. Thank you. So as usual, you could always give back feedback to Dr. Chad regarding the lectures that we have, how we can be able to improve, if you're learning and all that, because that's the only way we can be able to know where to improve better. So thank you so much. I want to wish each of you a good night, and we meet in our next lecture, probably next week on vascular. Thank you so much.